Welcome everyone, and this is Laura Dixon. I want to welcome you to today's program. This is Critical Access Hospitals, Conditions of Participation, Part 3 of a 4-part series. With this 4-part series, what we're doing is covering the entire Appendix W for Critical Access Hospitals. Now, I don't do a deep dive into many of them because some of these programs are 2 hours themselves in length. I'm giving you the highlights, the really key points that you need to hear in order to start your compliance program, to review your compliance program. So let's go ahead and start. By the way, on slide number 2, you have the email address for CMS. So this is, of course, why we're here today. If you have listened to the 2 previous sessions, great. Just kind of hang in there. But for those of you who this is your first time, the reason we're here today is so you do not get one of these. That is the statement of deficiencies when CMS puts back out to you. So how do you keep up with the changes? What do you do? What's the best resource? Always start by subscribing to the Federal Register. That's where the law is put. You'll get an idea about how much they have to cover. You also want to make sure that you have the most current manual. Last one was put out in February of 2020. A lot of changes were made during that update. However, there were also some items they didn't get around to. They were hoping to have them done by the end of 2020. Needless to say, the pandemic put a halt to everything. 2021 went by, still nothing, and now we're 2022. At some point in time, CMS had also started to do targeted infection control surveys. Well, needless to say, this happened to be in response to the pandemic. And that came out in March and then was updated December of 2020. What they did was they prioritized when the state survey agencies would actually do a survey. Now remember, again, in March, they cut them off because they didn't know what was going on. They had to get a handle on things, and they were busy looking at other issues. One other item I wanted to talk about real briefly was vaccine storage. You know, with the COVID, different types of vaccines and just routine vaccines, whether it's flu vaccine, pneumovax, whatever it happens to be. Again, updated it in 2020, and it talks about the cold chain because they were finding out through reports, observations, we were not doing that. We weren't keeping the vaccines at the temperature they were supposed to be. And in a method and in a container, refrigerator, that was optimal. Don't guess. Keep this information also very close, especially the toolkit, close to the vaccine storage refrigerator so your staff can access it. It's not going to do any good if it's locked up in the infection preventionist office, if it's locked up in somebody else's office. Well, let's go ahead and start in with the first topic that we're having during this part 3 of the 4-part series, and that's infection control. Also, the antibiotic stewardship program, that was new when they made the changes as a result of the hospital improvement rule. Now, hospital improvement rule, that's a shortened phrase for the very long memo that it came out. It was part of the burden reduction, transparency, et cetera, et cetera. So for prevention control and your antibiotic stewardship program, again, significant updates. The main title was Burden Reduction and Discharge Planning, Final Rule Memos, December 2019. This is where they put in, these are your new tag numbers, this is the new information, and sadly, again, interpretive guidelines for the rate procedures are pending, and that's for all of them. It starts on page 495 of this particular memo. Okay, for the next segment, I want to talk about this vast area called provision of services. I call it vast because it includes so much. And includes so much where in the acute manual, they break it out into their own segments, their own chapters. But for critical access hospitals, they combined them under provision of services. Now, I'm not covering the entire chapter of provision of services. I'm just covering 3 of them. And again, that's outpatient, lab, and nursing. And this is what's included in that entire chapter of provision of services. So that's outpatient. That's what they are having to be looking at. So what I want to do is now move over to lab before I get into nursing. Laboratory, basic lab services, so that there's immediate diagnosis and treatment. These are not your genetic testing we're talking about, very basic. Your Chem 7, maybe it's your full CBC. Maybe it's just a white count, whatever it happens to be. Your scope, what you do, must meet the needs of the patient. Again, if you're seeing a young population, Maybe you have a childbearing population. What would you expect to see and have to perform for those patients? And this is some of the testing that is included. This, again, is out of the manual. Urine dipsticks, testing for ketones, diabetes, hemoglobin, hematocrit, glucose, stool for occult blood, pregnancy tests, primary culturing. And what they're looking for here is then you can send it off to a certified lab if you can't do it. Again, the lab doesn't take very many pages. Let's switch over now to nursing, because this tends to be a little bit more involved. So as far as nursing, just like with any other service, overall, they're just responsible for the management and evaluation of care. So they must develop and maintain all of the nursing care policy and procedures. They're responsible for supervision of staff. They can do it themselves if they want. If you have a small enough nursing department, that's fine. But usually they do try to use managers, where then the managers report to the chief nursing officer. So let's go ahead with what time we have left here. I want to talk about discharge planning again. Normally, discharge planning is a separate topic, separate 2-hour session in and of itself, where I go into great detail on what's required, what are the changes, what you have to do. So here I'm going to hit the really big highlights and what those requirements are. Overall, you have to have an effective discharge planning process that focuses on the patient's goals for while they're there and their treatment preferences. You must, and this is a must, you must include the patients and their representatives as active participants in this process. Now, the patient may decline to participate, that's fine, but you at least have to include them. And if they say, no, I don't want to do anything, okay, just have to make sure they're still part of it. The evaluation must be done in a timely manner. You want to make sure you have enough time to get these arrangements made for their post-hospitalization care, and so that we're not delaying their discharge because, hey, we just didn't get around to it. So as far as the evaluation, document the results of what you got from that evaluation in the record and talk it over with the patient and or their representative. You have to arrange for development and initial implementation of the plan when the physician asks for it. If you do have to transfer a patient, do so only if you cannot provide the needed services. If you do transfer or refer them, of course, send along whatever information, medical information, that new place is going to need. And that includes, what was my course of illness? Summary. What treatment did I have? How did they respond? What were my discharge goals and my plan of care? What were my treatment preferences? The discharge planning evaluation must be in the record, and it must be used in doing the plan. So let me repeat that. The discharge planning evaluation has to be in the record, and you have to use that information when you're putting together the discharge plan. Some additional points. You can use telehealth, by the way, to meet the discharge planning requirements. You can. For critical access hospitals, they know telehealth is so crucial, so beneficial. Follow some of the requirements for in putting together your program to do that. Inform the patient that they can choose what Medicare provider and suppliers if they do need the services. You cannot limit qualified providers. And disclose any financial interest you might have in a home health agency as a hospital or that skilled nursing hospital. Again, there is a discharge planning worksheet. CMS has this. They're no longer utilizing it, but you can. That references in there. You will see this is on slide number 137. It does reference tag A806. That's from the acute appendix. So with that, I want to thank our moderator, and I want to thank everyone for attending, and I will turn it back to you to close us out.